I was asked to talk about predicting outcomes in rheumatoid arthritis, the role of biomarkers, but that's a huge topic and really needs more than 30 minutes. And so I've limited my talk to the role of molecular biomarkers. So I'd like to start off by defining a biomarker. And the Biomarkers Definition Working Group in 2001 published a paper in which a biomarker was defined as a characteristic that is objectively measured and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. So there are several types of biomarkers. There are clinical biomarkers, such as the swollen joint count, the tender joint count, patient global assessment, DAS28. There are biochemical biomarkers, which can be either proteins or nucleic acids or metabolites or other small molecules. And finally, there can be imaging biomarkers such as ultrasound, MRI, or even plain radiographs. The Sharp score is a biomarker. Bill Robinson talks about descriptive versus mechanistic biomarkers. Descriptive biomarkers reflect the state of a disease, but are not directly involved in the disease pathogenesis. And examples of this are the sedimentation rate and the C-reactive protein, which do not correlate very well with disease activity. Descriptive biomarkers provide diagnostic and prognostic information of limited value. On the other hand, there are mechanistic biomarkers which reflect the dysregulation of molecular pathways that are directly involved in pathogenesis, and these have the greatest potential to guide clinical decision-making and are more useful as predictive and pharmacodynamic biomarkers. Interested in why patients don't qualify for clinical studies, we embarked on a cohort analysis of corona to look at discordance of the erythrocyte sedimentation rate and the C-reactive protein with clinical disease activity. And we looked at over 9,000 patients in the corona registry who had active disease. So these were patients who were either in low disease activity, moderate disease activity, or high disease activity by CDAI, Clinical Disease Activity Index, which doesn't involve an acute phase reactant. So this avoided circular logic. And we found that 58% of these over 9,000 patients had a C-reactive protein below the upper limit of normal and an erythrocyte sedimentation rate of less than 28 millimeters per hour, which is the typical cutoff for clinical trial enrollment. Only 16.5% of the patients had both elevated, and then there was discordance with either the CRP elevated or the sedimentation rate elevated, but not the other in the remaining 25%. So acute phase reactant levels often do not correlate with disease activity as measured by joint counts and patient global assessment. So the ESR and CRP, while we order these frequently as biomarkers, do not really correlate with disease activity. To better assess disease activity, a multi-biomarker disease activity score was developed, and 396 candidate biomarkers were assessed. And performing a number of analyses to look for redundancies, this number was reduced to 12 biomarkers, which are shown in this Venn diagram. These biomarkers were correlated with the elements of the DAS28, the swollen joint count, the tender joint count, patient global, and C-reactive protein. Of course, one of the 12 biomarkers that correlated best with C-reactive protein was not surprisingly the C-reactive protein. In terms of the patient global assessment, 2 matrix metalloproteinases and resistin correlated, as well as a number of other biomarkers, which are shown in the center: IL-6, leptin, TNF receptor 1, VEGF alpha, and EGF, VCAM1, and serum amyloid A component, which correlated with everything, and then YKL40 correlated with the tender joint count. The MBDA score based on these 12 serum biomarkers is a proprietary equation. It's as complicated, I'm sure, as the DAS28, but it's proprietary, so we don't know what that equation is, but it results in a score that ranges between 0 and 100, rounded to the nearest integer. The disease activity categories were defined based upon a linear relationship with the DAS28 CRP. So an MBDA score of less than 25 correlated with DAS28 CRP remission, a score of 29 or lower correlated with low disease activity, between 29 and 44 correlated with moderate disease activity, and above 44 was high disease activity. So you've got this laboratory test, you draw the patient's blood, send it off to the laboratory, these 12 biomarkers are analyzed, the score is calculated, and then reported in terms of disease activity by these cutoffs. So in rheumatoid arthritis, this can be used as a laboratory test surrogate for DAS28. So instead of doing a swollen and tender joint count, asking the patient how she or he is doing, and then getting an acute phase reactant and calculating it, you can send this blood test off and get an equivalent indicator of disease activity for the cost of the blood test. However, that doesn't really add anything to what we do. We can calculate a DAS28 ourselves, but to predict structural progression or to predict relapse of disease activity is something that we can't do by assessing disease activity at the moment that we're examining the patient. So there are two studies that I'd like to talk about in which there was a post hoc analysis that looked at prediction of structural progression, the SWEFOT study and the Leiden Early Arthritis Clinic analysis, and then another study that was done in Erlangen, Germany, the RETRO study, which looked at prediction of relapse of disease activity. The SWEFOT study was a study that was headed by Ron van Vollenhoven when he was at the Karolinska Institute in Stockholm. He's now head of rheumatology in Amsterdam. And this was a study in which patients who had rheumatoid arthritis with less than 1 year of symptoms and no prior DMARD treatment, who were at least in low disease activity by DAS28, were treated with methotrexate monotherapy, 20 milligrams a week for 3 to 4 months. The patients who were non-responders to methotrexate were then randomized to either receive triple therapy in arm A or methotrexate plus infliximab in arm B. And if they didn't respond to triple therapy, they were then treated with cyclosporin A. If they didn't respond to infliximab, they were switched to etanercept. The primary endpoint at 12 months was the proportion of patients with a EULAR good response, and at 24 months, there was a key radiologic endpoint, the progression of the Sharp score, and multiple secondary endpoints. So a post hoc analysis of 235 patients from this study was conducted to look at the ability of the MBDA to predict structural progression. Just to remind you of the outcome of this study, there was a slight superiority, but statistically significantly better, where methotrexate plus infliximab led to a larger proportion of EULAR good responders than did triple therapy. I apologize to Jim O'Dell. In terms of radiographic progression, both groups progressed, but there was more radiographic progression with conventional DMARD triple therapy than with biologic therapy in Group B. So you can see here that the Sharp Van-de-Heides score progressed by about 6 points or 4 points at 12 months and by about 6 points at 24 months. Now, in this post hoc analysis, the MBDA score was measured in baseline serum samples, and patients were assessed for an increase in the Sharp Van-de-Heides score by at least 5 points, which is rapid radiographic progression after 1 year. And you can see in this graph on the right that of the patients who had a high baseline MBDA score, 21% had radiographic progression of at least 5 sharp points. So the high baseline MBDA predicted radiographic progression much better, or there was more radiographic progression in that group than among those who had low or moderate disease activity by MBDA. And when you look at the ability to discriminate among these three groups by MBDA score, high, moderate, and low, blue is high, red is moderate, and black with the open circles is low, looking at the correlation between MBDA score and radiographic progression in panel A on the upper left, CRP and radiographic progression in the upper right panel B, sedimentation rate DAS28 ESR in panel C, and the sedimentation rate by itself in panel D, you can see that only in panel A is there separation in terms of radiographic progression, where there's more radiographic progression, a shift to the left of the curve in the patients with the high MBDA score compared to moderate or low. So In terms of CRP in panel B, DAS28 ESR in panel C, or ESR alone in panel D, there's not really a good separation. So the MBDA score in the SWEFOT study predicts structural progression in early rheumatoid arthritis, and as a dichotomized variable where you look at high MBDA score versus low or moderate disease activity, the odds ratio for radiographic progression is nearly 4 compared to patients treated with triple therapy. So when choosing initial treatment in early rheumatoid arthritis, the MBDA may identify a subgroup of patients at low risk of structural progression. And the advantage here is that you get this test, and then you can choose appropriately which patients do not necessarily need as aggressive and expensive treatment with a biologic therapy, so that you can reduce the potential cost of treatment by predicting which patients may do just as well with conventional DMARD therapy. Another analysis to look at the same question was done in the Leiden Early Arthritis Clinic, where the MBDA score was also found to predict structural progression in rheumatoid arthritis. This is a group of patients that were collected at the Leiden University Medical Center in the Netherlands, 163 patients with rheumatoid arthritis, all of whom were on non-biologic DMARDs, sulfasalazine, methotrexate, and hydroxychloroquine. Fewer than 10% were receiving corticosteroids, and none of these patients were receiving a biologic therapy at their first study visit, and fewer than 5% were receiving biologics at the time of follow-up. These patients had annual radiographs of the hands and feet, baseline and annually thereafter, and an MBDA was drawn at each visit. And you can see the baseline characteristics on the right. Patients were typical of patients in a rheumatoid arthritis study. Mean age was in the mid-50s. 2/3 of them were female. In this study, this was not very early rheumatoid arthritis. The disease duration, the median disease duration was 4.6 years. 2/3 of the patients were seropositive, either rheumatoid factor or anti-CCP antibodies, and they had a low number of swollen and tender joint counts and a relatively low median CRP of 0.8. What you can see here on the left is sharp score progression over 1 year with a change of 3 or more, and on the right, a change of 5 or more. So on the right side, you see rapid radiographic progressors, and on the left, you see radiographic progressors. What's important to notice here is that the patients with high baseline MBDA scores had a higher relative risk of progression than patients with lower baseline MBDA scores. And even within that category, although the category is 44 and higher, the higher the MBDA score was within that category, the greater the relative risk of progression. And the same was borne out in the patients when analyzed for rapid progression, where you can see that the relative risk of rapid progression was 17.4 with reference to the low MBDA score group. So a high MBDA score is a fairly good predictor of radiographic progression in patients treated with conventional DMARDs. And in a multivariate analysis of risk factors for radiographic progression in this group, the SHARP score at baseline bore out in the model for the change in the SHARP Van de Heide score of more than 3, but the MBDA score was highly significant as really the major contributor to the prediction of radiographic progression. Looking at structural progression based upon swollen joint count, what's important to notice here is that in patients with no swollen joints, a high MBDA score indicated that 32% of those were progressors. Looking at C-reactive protein, patients with a C-reactive protein of less than 10 milligrams per liter, which is essentially a normal range, 39% of those who had a high baseline MBDA score were radiographic progressors. And finally, DAS28 CRP in remission, less than 2.67, patients who had a high baseline MBDA score, 44% had radiographic progression. So even where the patients have otherwise indicators of controlled disease, the presence of a high MBDA score in those patients indicates a greater risk of structural progression over 1 year. So the MBDA score in this cohort is a predictor of future joint damage in patients with established rheumatoid arthritis receiving non-biologic DMARDs. It is independent of and stronger than established risk factors such as serologic status, the swollen joint count, the C-reactive protein, and the DAS28-CRP, and it may help to determine which patients need treatment intensification to prevent progressive joint damage. And the converse of that is that patients with a low MBDA score whose disease is in control probably do not need aggressive therapy and might do just as well with conventional therapy and not the addition of a biologic. So what about predicting relapse with this test? This is a study called the RETRO study, which was reduction of therapy in patients with rheumatoid arthritis in ongoing remission. Patients were screened, and patients who were in DAS28 remission for at least 6 months prior to baseline were randomized to one of 3 arms. Arm 1 is the control group. They had no modification of treatment over 12 months. Arm 2 was reduction of all conventional and/or biologic DMARDs by 50% over 12 months. And then Arm 3 underwent this 50% reduction during the first 6 months, and then withdrawal of all conventional DMARDs or biologics during the second 6 months. So you've got 3 arms. You've got no modification in Arm 1, reduction across the board in Arm 2, and reduction for 6 months, and then discontinuation in Arm 3. And what did they find? Well, the baseline MBDA scores in patients who relapsed were higher in patients who tapered treatment, Arm 2, and patients who stopped treatment, Arm 3, than patients who had no relapse. So the baseline MBDA score being higher predicts potential relapse in these patients. When you add ACPA, the anti-citrullinate protein antibody, which is a biomarker, when you add ACPA status to the baseline MBDA score, you find that in patients who are ACPA negative and MBDA negative, who have a low MBDA score of less than 30, only 13% of those patients relapse over 1 year. Whereas if you have both positive, the orange square, the lower right-hand corner of that 4x4, over 75%, 76.4% relapsed who are both MBDA positive with a moderate to high MBDA score and ACPA positive. And this Kaplan-Meier survival curve shown on the right, the survival, the loss of remission over 1 year is greatest in the ACPA positive, MBDA positive patients, which is this purple curve, and is lowest in the blue curve at the top, which are the double negatives. So the MBDA score can be used as a laboratory surrogate for the DAS28, but it is best used to predict structural progression or relapse of disease activity. As a predictive biomarker, however, these post hoc findings require prospective validation. These are retrospective analyses of studies that were designed for other purposes. And there is a prospective outcome study of MBDA-guided care compared to usual care that is now ongoing. 2 arms. In one arm, patients are, the physicians are given the MBDA score to drive therapy, and in the other arm, the MBDA score is done, but physicians are not made aware of that. And the ultimate, and there are rules that if your MBDA score is less than 44, you don't advance to biologic therapy as quickly. And the primary outcome is the change in the DAS28 at month 6, and also the proportion of patients using biologic DMARD or JAK inhibitor to month 6. Another biomarker is 1433 ETA, and 1433 proteins are a family of intracellular chaperones expressed exclusively in eukaryotic cells. There are 7 isoforms, and these bind to and regulate biologic activity of over 200 intracellular proteins involved in protein trafficking, cellular signaling, and cytoskeletal transport. These proteins are released from exosomes by activated dendritic cells, T and B cells, macrophages, and epithelial cells, and overexpression of these 1433 proteins has been associated with worse outcomes in cancers, neurodegenerative diseases, and Creutzfeldt-Jakob disease. So these proteins have been used as biomarkers to assess outcome in malignancy and neurodegenerative diseases. 1433 ETA is expressed at higher levels in rheumatoid arthritis patients than in healthy individuals or in patients with osteoarthritis, ankylosing spondylitis, and gout. And in inflammation, 1433 ETA binds to its receptor, activates certain intracellular protein kinases, which result in increased transcription both of pro-inflammatory cytokines and matrix metalloproteinases and rank ligand, resulting in increased inflammation and increased joint destruction. And so 14-3-3 ETA levels are higher in rheumatoid arthritis patients, both established in early rheumatoid arthritis than in controls, as well as in other diseases such as osteoarthritis, ankylosing spondylitis, and gout. So it's potentially a marker for rheumatoid arthritis, as is ACPA or rheumatoid factor. And looking at a patient population of early rheumatoid arthritis, 99 patients or 124 patients with established rheumatoid arthritis, looking at the addition of rheumatoid factor to ACPA, you detect 22% more early rheumatoid arthritis patients or 11% more established rheumatoid arthritis patients than ACPA alone. If you add 14-3-3 ETA in this small sample, you detect 32 or 11% more patients. And if you look at all three, ACPA, rheumatoid factor, or 14-3-3 ETA, there's a small incremental improvement in detection of 8 and 9% in early and established rheumatoid arthritis, respectively. There are higher median 14-3-3 ETA levels in rheumatoid arthritis patients with erosive disease, both in early rheumatoid arthritis and established rheumatoid arthritis. And so the question is, can you predict clinical and radiographic outcomes in patients with recent onset inflammatory polyarthritis? This analysis was carried out in a Canadian cohort of patients with early undifferentiated polyarthritis at the Centre Hospitalier Universitaire de Sherbrooke. And these patients had at least 3 swollen joints for up to 12 months, and they were followed prospectively at baseline, 18, 30, 42, and 60 months. And as of the time of this publication or this analysis, nearly half of the patients had completed 5 years of follow-up. The baseline patient characteristics are shown on this slide, similar to those of the Leiden cohort, although here, symptom duration, median symptom duration was 3.1 months. So this was a very early population, and only 40%, 45% were seropositive, and they had more swollen joints than the Leiden cohort. Here, the median number of swollen and tender joints was 9, and the CRP median was 13.1. So looking at patients at prediction of SDI remission, 14-3-3 ETA, 2 levels, the cutoff was 0.5. So in blue, you see patients where the baseline 14-3-3 ETA level was less than 0.5 at baseline. Red is 0.5 or higher. So SDI remission was more commonly seen in patients that had a lower 14-3-3 ETA at baseline. And in terms of radiographic progression, just the opposite was seen. There was more radiographic progression in those patients who had the higher level of 14-3-3 ETA at baseline. So 14-3-3 ETA is a serologic marker that can be used to detect rheumatoid arthritis in patients who are rheumatoid factor and ACPA negative. It predicts radiographic progression, where patients with baseline levels of less than 0.5 are at lower risk for progression and may not need as aggressive treatment. And it also predicts clinical remission, where patients with a higher baseline level may require treatment intensification to better control disease activity. However, this requires further study, post hoc analyses of clinical trials, and prospective cohort studies, such as were carried out for the MBDA score, and also a randomized clinical trial of this test as utility as a predictive biomarker. I'd like to now turn to the third of the 3 biomarkers that I'm going to talk about, and this is calprotectin. As Jack alluded to in the earlier discussion, fecal calprotectin is used by gastroenterologists to assess disease activity in inflammatory bowel disease. Calprotectin is a heterodimer of 2 S100 calcium-binding proteins. These are myeloid-related proteins, or MRP, and they're called MRP8 and MRP14, or S100A8 and S100A9. And the heterodimer of these 2 is called calprotectin. It's expressed by granulocytes and monocyte macrophages during early differentiation, but it's absent from mature macrophages and lymphocytes. And you can see here in rheumatoid arthritis synovium, it is present in the synovial lining layer adjacent to the cartilage pannus junction. So here's a higher power view. and in red you can see the calprotectin staining, and in the osteoarthritis control, here's the synovial lining layer, and calprotectin is absent. So calprotectin is translocated from the cytosol to membrane structures with inflammation and activation of monocytes, and it may be secreted, and it's released at sites of inflammation, and that's why in the bowel, fecal calprotectin is a biomarker of intestinal inflammation and inflammatory bowel disease, and calprotectin levels are elevated both in synovial fluid and the systemic circulation in patients with active rheumatoid arthritis. And a number of papers have been published, not very good papers, but small studies that have suggested that serum calprotectin levels decrease in rheumatoid arthritis patients who respond to treatment to adalimumab, etanercept, infliximab, rituximab, and tocilizumab. This is a paper from Daniela Gerlach's group when she was in Amsterdam by Choi and colleagues from the Annals of Rheumatic Diseases, published in 2015, that looks at baseline calprotectin levels in patients who respond to biologic treatment for rheumatoid arthritis. Adalimumab, infliximab, rituximab, the patients with a good or moderate EULAR response have higher baseline calprotectin levels than patients who are non-responders, and this might suggest that the more active disease you have, the more room you have to improve, and that might be the explanation for this, but certainly baseline calprotectin levels can be used as a one dimension looking at potential response to biologic therapy. A better study was done in Scandinavia by Berner Hammer and colleagues that was published in the Annals of Rheumatic Diseases in 2010, and this looked at calprotectin predicting 10-year radiographic progression in rheumatoid arthritis patients. This looked at about half of the Eurodisc cohort of patients with rheumatoid arthritis of less than 4 years duration, and these patients had both at baseline and 10 years calprotectin levels measured and radiographs. And you can see here in this probability plot that the greatest radiographic progression was with highly elevated calprotectin levels. Lowest was with normal calprotectin levels, and intermediate elevation led to intermediate radiographic progression. In terms of association with the change in the Sharp score, calprotectin was statistically significantly associated, almost missed, but it was 0.045. Anti-CCP positivity was more highly associated with structural progression. So calprotectin in rheumatoid arthritis can be used as an acute phase reactant reflecting synovial inflammation. It can predict radiographic progression where patients with a high baseline serum calprotectin level of greater than 2.545 milligrams per liter are at higher risk for radiographic progression and may need more aggressive treatment. And it also may be used to predict response to treatment where patients with higher baseline serum calprotectin levels may respond better to biologic treatment. Again, like 1433 ETA, these are post hoc analyses, and these will require further study, both analyses of clinical trials and cohort studies and randomized controlled trials for use as a predictive biomarker. So, in summary, just before I summarize, there are other biomarkers, there are other molecular biomarkers. Certainly, powered Doppler ultrasound suggests activity of disease or indicates activity of disease, and patients with active synovitis as detected by powered Doppler have a worse prognosis if left untreated, work that was done in Paul Emery's group in the around 2007, published in Arthritis and Rheumatism. Powered Doppler is another approach. MRI, other imaging biomarkers can be used as well. But as I said, the MBDA score, 1433, ETA, and calprotectin each correlate with radiographic progression. 1433 ETA may predict clinical remission, and calprotectin may predict response to biologic therapy. The combination of molecular with imaging biomarkers may better discriminate between patients with better and worse prognoses. And finally, the utility of biomarkers to predict rheumatoid arthritis outcomes must be validated in prospective randomized controlled trials. Thank you for your attention.